So I'm gonna come back here after this lecture to explain to you about the CEREC and how to use the software. For now, I have Dr. Porto here. He's gonna give you a lecture about inlays, onlays, and overlays. Please pay attention to this lecture because it's super important. For now on, I'm gonna be talking about indirect procedures, inlays, onlays using CEREC. This is super exciting. All right? Dr. Porto.
Good afternoon. Today we are going to start a new topic, and it's a new concept for you, but it's not a new concept in name. The thing I want to start the lecture with you, you start with you thinking about a patient who comes to your office, and you are going to do a malma restoration. A simple class 2, like you have been doing on the lab. Imagine you are going to do the rubber dam, and then you go to remove decay. And imagine that it's a small cavity, all right? Class 2. What you're going to do, you are going to do the malma restoration, and this patient will go away. It's okay. You finish the treatment, right? When we are going to do the indirect restorations, what happened? The patient will come, but let's imagine the same situation, okay? A class 2, but a large cavity, all right? What will happen? We are going to prepare this tooth to receive an indirect restoration. And the preparations for indirect restorations are different from what you have been doing for malma and composite resin. The main thing, and it's important to understand, is that I would not finish if I'm not working with optical impression. We are going to talk a little bit about this during the lecture. But if I'm not going to work with optical impression, I'm not going to finish the treatment on the same appointment. Okay? What I have to do, I have to do a regular impression or optical impression. Okay? So, let's understand what happened in a step-by-step on a direct procedure and indirect procedure. When I work with direct procedures, I can work with composite resin, amalgam, and resin modifier glass ionomer. Alright? And the step-by-step, I'm going to do the isolation, remove decay. I'm going to prep this tooth to have a resistance form, the retention form. Okay, all this I'm doing in the time that I'm preparing this tooth, and the convenience form to receive this material. All right. And I'm going to the material placement, go occlusal adjustment, and do the finish and the polishing. So, when I'm going to work with indirect procedures, I have different type of materials that I'm going to use with indirect restoration. It's not me, it's not you, the professional, that's going to manufacture the restoration. Instead, you're working with optical impression, if you have a chair side. Okay? So, indirect procedure, I will work with ceramics, metals, PFMs, composite. This is lab composite. It's not the same resin, composite resin that we work on the office. Okay? And we have two zirconia ceramics. Some of these materials we will work to do crowns and ribs, and some others to do inlays and onlays. That is what we are going to learn today. Inlays and onlays and overlay too. So the beginning is pretty the same. I will do the isolation. I'm going to remove decay. Okay, but here imagine probably the decay or the cavity is bigger than when I'm going to do a direct procedure. So I'm going to do the resistance form. It's a little different from the direct procedure. We are going to see that. And the retention form, I don't have a retention form for indirect procedures. Okay? Because the indirect procedures, I will have the retention through enamel and dentin adhesion. Okay? Through a cementing process. It's different from what we have until now. And I'm going to do the convenience form. So here is the point that I said to you that we have two ways to work with indirect procedures. If I have the regular impression, I'm going to have a plaster model, and I'm going to send this to a lab technician. And this lab technician will work on this plaster model and will create the restoration on the prep that you already did on the tooth. Okay? When we work with regular impression, we must do a provisional restoration because we cannot send this patient home without provisional because the cavity will be large, right? And then we probably will wait between 1 and 2 weeks until we receive back from the lab technician the restorations or the restoration. And then we go to the cementing process, place the final restoration. If I have available optical impression, it's a little bit different. On the same appointment, I'm going to do the optical impression, and I don't need to do provisionals because I'm the dentist, or if you have an assistant, will work on the creation of this restoration on the computer screen, and then I will send the digital file to the milling machine, and after 10 to 15 minutes we will have the restoration ready to be cemented. All right? Is everything good so far? All right. So the important is on the same appointment we will deliver this restoration to our patients. Okay? So here we can see the difference between these two ways of doing restorations. Direct procedure, where we are going to work inside the mouth, we are going to create these restorations. If it's a amalgam or if it's composite resin, doesn't matter. If I'm going to do an indirect procedure with regular impression, I have the plaster model. The lab technician will create these restorations for us. Or if I'm going to also work in direct procedure but optical impression, we will have this on a computer screen, and then we will create the restoration. And remember, on the same with optical impression, on the same appointment, the patient will be done. And here, when we work, I want you to understand this because it's very important. Like, it's a different concept of the class 1, class 2, and the size of the preparations are bigger. So, when we are going to work with this type of preps, we're not going to work anymore with carbide burs. And how it works a carbide burr, it's very similar to a knife. It's cutting the enamel and the dentin. But to do these preps, we are going to work with diamond points that's similar to a cheese grater. It is going to wear the enamel and the dentin. It's not going to cut anymore. Okay? So here we see that on diamond points, we have attached to the metal, the steel, the diamond. And the diamond is long-lasting than our carbide was. So once we have large cavities here, we need a rotatory instrument that is long-lasting. Okay? Because when we use the carbide burrs, you see here between the blades, we will have the enamel and denting that is going to be cut by the cutter. Okay? Here it's going through a wear process. We have much more control, and our rotatory instruments is long-lasting too. And the important thing is that all these kind of prep, of this type of preps, we will have a specific diamond point shape to work with that. It's similar to the class 1, class 2 preps. If we were working with 330 or 245, the shape of the burr will give you the characteristics of our prep. The same thing with diamond points. The shape of the diamond point will give us the characteristics that we want in this prep. And we are going to see what are these characteristics that we must have to fit these restorations. So the concept here is when we have an inlay prep, we consider an intracoronal restoration. Okay? And if we have only, here we can call half crown or overlay, is the same thing. Okay? Half crown and overlay is the same thing, but both are different from onlay. We're going to see this difference, right? And when we have only half crown, it's an extracoronal concept because we are going to include the cusps on our preparation. We're not going to work only inside the crown in an intracoronal way. We're going to include the cusps. So, including the cusps, it will depend if it's an only or half crown. And we are going to understand this. So the concept of inlay, we can see here, it's very, very similar to a class 1, class 2. Okay? But again, it's bigger. Okay? And we will see that we need to have much more clearance between the teeth to do an inlay preparation. And when I have the onlay, what's going to happen? Look, I'm going to include the cusps inside my prep, and I will have a shoulder on these cusps. Depending if I have cusps, undercut cusps, I will need to include this. If I have fractured cusps, large cavities, I will need to choose between inlay and onlay, and which cusps we will need to include on this prep. And the half crown or overlay, I'm going to include all the cusps. Okay, it's like a crown, what we call half crown because it's very, very super gingival. Okay, I'm not in gingival level. All right, it's very, very super gingival. It's a half crown. In the middle of the tooth to the occlusal. Okay, got it? So here, let's understand the two concepts here. The old concept that a lot of dentists have been using to work with amalgam restorations, the composite and crowns, and now why we're going to work with the Inlay Onlay restorations. It's like an evolution of the traps and the materials that we have in dentistry today. So here, it's what I have here. It's I have a large class 2, okay, and normally we can work with amalgam here. No, not a problem. In this type of prep too, you saw last lecture that we work with this type of prep. with amalgam, we need to like the amalgam pin, some retention grooves. Remember that? So now, what we are going to do on this type of preps is that we're going to work with this Inlay Onlay preps and thinking different with the material that we are going to use to restore. The composite resin we normally use on class 1, class 2, but we will see that some kind of class 2 we can go and work with an inlay restoration instead of working with composite resin. Because what's the main problem of composite resin? The shrinkage. Okay? And in large cavities, we will have issue problems, adhesion issue issues. Alright? So, why I am choosing to do an inlay onlay or composite resin amalgam restoration? Because of the shrinkage of the material, because of the type of the crash. Right? So I have a new way to work with this type of restoration. And we can consider a borderline from a composite resin and an inlay restoration, thinking this way. Imagine here the intercusp distance. All right? So when we have 1/4 of this distance, okay, 1/4 of the intercusp distance, our isthmus will going to be 1/4. We can work with composite resin, no problem. When we have 1/3, the same thing, composite resin, right? But if we have more than 1/3, like half of the intercusp distance, we must go with an inlay. Because the shrinkage of the material will happen outside the mouth. On the plaster model, or if I'm going to work with Cartan technology, I will not have the shrinkage. Okay? So now, the way we should think is on this type of preps, it's much better if I go with an Inlay Onlay or crowns here, half crowns, onlays, and leave the composite resin for small preps. This is the main difference. And it's very important that I understand that I can just leave the composite resin for small preps and work safely with Inlay Onlay and over. The Inlay, the definition is they are type of preparation limited to dental structure, and it's just like a box. Like I told you before, it's the same thing of class 1 and class 2. Look here, you can imagine, oh, I have a class 1 here, so I'm going to work with composite resin. Depends the size, and you can follow that rule with the intercusp distance. If I have more than 1/3, even if it's a class 1, go and restore this tooth with an inlay, an indirect procedure. Here is the shape of extracoronal, only in half crowns. The definition there, preparation where it's necessary to have cusps coverage and or other aspects of the tooth. So, on onlay we will have the inlay preparation first, and then we go to include the cusps. We are going to start the onlay prep with an inlay prep. And then we do the cusps coverage. All onlay preparations and overlay preparations will have the occlusal box and proximal box. So we are always going to start with an inlay preparation. And when we go to an onlay, until 3 cusps, and if I have an overlay, I will put all the cusps inside the prep. Good? Here we have some indications for inlay onlay and overlays. Desire for aesthetics. Some patients will come to us to change those old normal restorations for aesthetic material. A lot of patients today have that, and the demanding for aesthetics is just increasing. Large cavities. We are not going anymore with composite resin. We go with indirect procedure. Endodontically treated teeth. We are going to increase the resistance of endodontically treated teeth with indirect procedures. So we are going to restore endo. We must think in using an indirect procedure. We desire that margins be placed on enamel. It will be safer, all right, if we have these margins always placed on enamel. And for now, let's think about that we prefer to have supragingival margins, okay? And a new topic, you will learn how to work with gingival level or subgingival margins. But now, let's just think about having supragingival margins. Okay, it's preferable for this type of restoration, mainly because of the technique. Okay, we are going to a cementing process, the same thing, the same way of composite resin is sensitive. Contraindications. Conservative cavities. I'm not going to do an inlay on a small prep. Young teeth, large pulpal chamber. If I'm going to do an inlay on a teenager, they have large pulpal chamber, and we have risk of pulp exposure. So it's not indicated. Teeth with short clinical crown, the same thing. We need to see how big is the pulpal chamber. Okay, because short clinical crown, if we not wear and prep the tooth the right way, the material, the ceramic, is brittle, so could fracture. And parafunction habits and deep intercuspidation, it's the same thing, it's a contraindication because the material is brittle. So it could fracture. Well, let's talk a little bit about the advantage and disadvantage now, but I'm going fast because you have this on vital source. So if you have any questions, please ask me during the advantage and downside, right? Compared with amalgam and composite resin, we have all the indirect materials. They have improved physical properties. We have a variety of materials and techniques, like we see regular and off compression. They are rare resistance. right? Much more resistant than a composite resin. And reduce polymerization shrinkage, because this is going to happen outside the mouth. And if I'm working with optical compression, I don't have. Supporting of remain tooth structure, because normally we're including this tooth structure on prep. We have better control of contours and contacts. Why?
Just outside the mouth.
Yes. Perfect. It's manufactured outside the mouth. It's much easier to create the restoration. We have biocompatibility and good tissue response. The ceramics are inherent to the softer tissue and increasing auxiliary support to the tooth. So, because of all these advantages, the inlays and onlays have better marginal adaptation, anatomic form, color match, and overall survival rates than do direct composite restorations. Here we have 4 indirect restorations on these 4 teeth, and we cannot see the margin. And we can see that we have a very good aesthetics here. It's completely different, and after some time, like 3, 4, 6, 7 years, we still have a aesthetic pretty similar to that on indirect procedures. Some disadvantages: increase cost and time. It's more expensive to do an indirect procedure. And the time is increasing if we are going to work with a regular impression. With optical impression, it will not happen, because we are going to do it on the same appointment. Technique sensitivity, okay? Because of the cementing process. The composite resin is the same thing. We are working with adhesion in both procedures. We have a difficult trying in the liver. Difficult trying because we have to take care of the material when we are going to do the trying, because the material is fragile. It's brittle. And if we not pay attention, you can fracture while doing the trying. So it's very, very important to handle with a lot of attention. Sometimes we're opposing dentition restorations because it's hard. We don't have a big clinical record as amalgam restorations, like we have 25, 30 years inside the mouth. We don't have this with indirect procedures yet. And another important thing, they are non-repairable. If the ceramic fractures, we cannot repair the ceramic. We cannot put a composite resin there. It will fracture in the next 15 days. And now we are going to talk about some guidelines for the preparation. This slide is very important. It's Dr. Roberto 5 Commandments. I'm kidding. You need to memorize this for your final exam. So let's see one by one. And you don't have these on vital source. Smooth tapered walls will ensure us good internal adaptation. Preparation in inlays, onlays, and overlays, tapered walls. Always. Not undercut walls. Smooth, well-defined margins will aid us in margin detection and fit. Okay, we need to have a very good defined margin. Rounded internal angles will ensure specificity and prevent fracture. When we have sharp angles, we have a stress concentration on sharp angles. We have stress concentration both material and tooth. Exit angles and margins approaching 90 degrees. This will ensure poke of ceramic at margins for strength. We cannot have thin parts of ceramic. And we must do adequate tooth reduction to ensure the strength of ceramic material. So if you need to have 1.52 millimeters, reduce that cusps 1.52 millimeters. Avoid false conservatism. All right? It's very important for you to know the material you are working with, work with the proper material. All right? And on this kind of situation, on this type of situation, avoid false conservatism. So the walls for inlays and onlays, remember I told you I will always start with an inlay thread. It's my first step. 6 to 8 degrees wall taper is optimum for internal adaptation and margin fit. Always tapered walls. Never undercut or parallel. The restoration will not fit here and here. It's impossible. You will have a hard time trying to fit the restoration on this type of walls. Over-tapering leads to thinner occlusal margins and increased margin stress as the margin approaches to the cusp. So we cannot over-taper too because we will have thinner margins on the ceramic. Keep the 6 to 8 degrees in mind. And again, undercut is not necessary for good margin. On the proximal box shape, unfortunately you cannot see. Okay,
I can see it.
you can?
Yeah.
You can see? Can you see
There.
the yellow?
Yeah, really.
Right. So yeah, I will try to help you. Here we have, I will try to explain you. I will have the contour here. It's rounded. It's rounded. It's the way it should be. Okay? And here we have a sharp angles that we cannot have these sharp angles because of the stress concentration. You have stress concentration here and will not fit the restoration. It's difficult to fit any stress concentration. If you are using the correct time on point, you don't need to worry too much about this. It's important that you know how it must be, the way it must be. But if you work with the correct time on point, you will have the prep rounded. So rounded and smooth box shape avoid sharp corners. Okay. Walls again should taper 6 to 8 degrees. The smooth floor with areas may inhibit seating and avoid sharp internal angles like this. Okay? If you don't have the right diamond point, don't go for indirect procedure. If you don't have the shape of the borders of the diamond points rounded. Here, the proximal margins, it's going to be different from class 2. Here we must have clearance of 1 millimeter. It's more than a class 2. Because if we don't have this 1 millimeter clearance, we'll have a hard time trying to fit the restoration. So, we need to remove the proximal area, okay, to avoid connecting surface. We can see here another important guideline. Thin ceramics margins are prone to fracture, like it's a brittle material. So, too sharp like this, we almost have a bevel, and probably your indirect restoration will fracture here, and we will have an open margin here. It's going to have micro leakage, and you will need to do it again. The way it should be, it must be, the exit angle, it's very similar to the reverse S curve, at 90 degrees with external walls of the tooth. Okay? If we don't reduce enough the tooth, this kind of fractures definitely will occur. It will happen. So, again, if you need to reduce 1.5 millimeters, reduce 1.5 millimeters. I love ceramics. I like to work with ceramics. But we must follow the guidelines. Work with this. So it's important for this lecture for you to understand the difference between composite and the indirect procedure. All right? And remember to memorize that 5 commandments. Okay? Today we are going to stop here, and then the next week we are going step by step on tooth preparation. Okay? Do you have any questions? No? All right. Thank you.